Dear George, thank you very much for this kind introduction. It is always a pleasure to be here and to talk about aortic stenosis. So, ladies and gentlemen, I will indeed talk about asymptomatic aortic stenosis, which is indeed in contrast with symptomatic aortic stenosis. So talking about asymptomatic disease implies to some extent talking about symptomatic disease with a particular focus on the elderly. As we all know, aortic stenosis is a progressive disease that shares similarities with atherosclerotic disease, lipid deposition, inflammation, ossification, calcification that have been shown in the valve with macrophages and all kinds of inflammatory processes. Unfortunately, so far, we do not have a medical means of delaying aortic stenosis progression, although we should control for all the associated risk factors that are present in these patients, such as hypercholesterolemia. And indeed, we see subtle morphological changes in some patients, which we call aortic sclerosis, and then a progressive disease to the full-blown picture of calcific aortic stenosis, and often there is the predisposition of bicuspid aortic valve disease that is underlying the disease. And more we realize that obviously aortic valve disease also has implications on the ventricle. So it is not only the mechanistic obstruction to blood flow, but it has direct repercussions on the ventricular function, leading to adaptive responses such as hypertrophy of the ventricle, and associated with that diastolic dysfunction, fibrosis, impaired longitudinal strain, reduction in coronary flow reserve, and in some patients, in the end also, it may lead to pulmonary hypertension or to associated valve disease, such as mitral valve disease. And I think we have to keep the whole picture in mind when we talk about aortic stenosis, even when talking about asymptomatic disease. And as Ross and Braunwald have shown in this legendary illustration dating back from now more than 50 years ago, there is a latent period where patients are asymptomatic and where they do fine. And once that symptoms occur, such as heart failure, angina, or syncope, the prognosis is dismal, and most of these patients will die. Obviously, this study dates back from an era of rheumatic heart disease, and it is a post-mortem analysis. So all these patients had died, and the authors looked back in time to figure out the time delay between symptom onset and mortality. But the concept still holds true. More recent catheter interventional studies where patients were randomized initially to conservative management strategies also show this poor outcome. So obviously, if patients become symptomatic, it is a turning point. Now, what about the asymptomatic patient? Can we wait until symptoms develop? And this was a question we addressed in the year 2000, where we followed asymptomatic patients with severe aortic stenosis. And we were able to show that these patients overall had a survival that was comparable to an age and gender matched population. But there is one but. These patients underwent regular control exams. They were called back to be seen every 6 months with scheduled exams. And you could see a slight difference in mortality, so there might be subgroups in whom this may not truly apply. Now, another point when talking about symptoms or asymptomatic patients is the definition of symptoms. And obviously, wherever you look, it comes down to a subjective perception, so subjective indication of disease as perceived by the patient. And obviously what we want to do, we want to objectivize what the patient really has. Is the patient symptomatic? So we ask the patients, do you have symptoms? And this can become tricky. Sometimes it is useful to ask the partner of the patient. Usually a wife is more objective in the assessment. She will say, well, obviously he has symptoms. Sometimes it is more subtle when you ask specific questions, and this is where experience comes into play. How many floors can you walk up? And then the patient will say, well, after one floor, I'm short of breath. But if you ask him, do you have symptoms? He may have said no in the beginning. And you may also challenge him and take him up 2 flights of stairs, and then you may know. And this is why there is also a role for exercise testing in apparently asymptomatic patients to confirm that they're truly asymptomatic. And it has been shown that it is a safe test if it is performed under controlled circumstances, and up to 1/3 of the patients who pretend to be asymptomatic will have symptoms during the exercise test. So it is a useful test, but as I've said before, sometimes just taking a patient up for 2 flights of stairs may give the same answer. But there is a limit, because it is the positive predictive value of the exercise test is particularly high in physically active younger patients. But in inactive patients, mild dyspnea might be non-specific. So if you have got an 85-year-old patient who has orthopedic problems, the exercise test might be inconclusive. So there is another addition of difficulty in assessing symptoms in the very elderly. And in terms of objectivizing, biomarkers are attractive, and so far the best biomarker available is BNP. And it has been suggested, obviously, since BNP is not specific, it is sensitive but not specific, depends on renal function, gender, and age. So you have to correlate it to the age and gender matched expected value. And if that value is 3 times above the expected, it is probably predictive of poor outcome, or certainly predictive of poor outcome, and may justify as an element an intervention on the aortic valve. But in that case, and particularly in the elderly, it is important to look at serial values, at the evolution. If something is changing and kidney function, for example, doesn't change, it is predictive of unfavorable outcomes. And calcification also matters. If a valve is calcified, the event rate is significantly higher. You can see this even in mild to moderate disease, but more importantly in severe disease. If a valve is not calcified or mildly calcified, the expected asymptomatic phase might be longer. You can see this usually in patients with bicuspid disease who are younger. But if the valve is already calcified, calcification will beget calcification. Progression is usually more rapid. And then ultimately, the absolute degree of severity is going to be higher. We need additional factors to differentiate between high and low risk patients with aortic stenosis, because we have issues when managing these patients. One of the issues is a treatment delay. These are data from Canada from 1990 to 2000, just highlighting the issue of waiting lists. And it is a waiting list from the primary care physician to the internist, to testing, to procedural booking, and finally to surgery or intervention that can be up to 9 months. And that was back in the 90s of the last millennium, we can now say. And there's undulation. I think situations became better. On the other hand, my impression is that our healthcare systems are strained right now, and waiting times for intervention are again on the rise. And there is another delay. It is not only the delay from the primary care physician to surgery or intervention, there is the delay before the patient has symptoms, but he doesn't see the primary care physician, or the primary care physician doesn't yet think about severe aortic stenosis. So in practice, we see half of our patients that we manage, when we see them the first time in a tertiary center, already have severe symptoms. And then there is again a delay. So this is why I think, and in particularly for the elderly, but not only, also for the younger, we need structured pathways of managing these patients. And this is why we were promoting the concept of a heart valve clinic, where you see these patients in an outpatient setting, and where you were able to follow these patients, know the patient, detect dynamic changes in lab values, in the echo, and then be able to take expert decisions regarding intervention, but also regarding a follow-up and a structured follow-up pathway. And what we can see is that the heart valve clinic experience shows that in that experience, patients who are symptomatic at the first presentation on average have been symptomatic for 1 year. So again, this huge delay. And those who are enrolled in a follow-up program can be detected with a delay of 3 months after symptom onset. And although all of our patients are instructed to report symptoms immediately, only 20% will do so, call us and come early. 80% will wait for the next scheduled exam, so this is why also scheduled exams are important. But on the other hand, you may want to think about high-risk patients whom you want to take out of this waiting system, out of this problems of waiting times, late symptom reporting, and high mortality on waiting times, and in whom earlier intervention, judging the risk of intervention and potential risks of reintervention might be justified. And indeed, patients who have a significantly calcified aortic valve, together with a rapid hemodynamic progression defined as an increase in peak aortic jet velocity of more than 0.3 meters per second per year, constitute a high-risk population, where 80% will need surgery within 2 years. And since that is such a high-risk group, it is worthwhile to consider elective intervention in this group, calcified valve with a rapid hemodynamic progression. And just highlighting the entire spectrum of aortic stenosis severity from moderate to severe and to very severe disease, you see that these patients, when they have a peak velocity greater than 5 meters per second, are very likely to need surgery in the near future. And these patients actually also have a high transvalvular gradient. 4 meters per second, which is the threshold of severe disease, corresponds to 64 millimeters of mercury, 5 meters to 100, and 5.5 to 121 millimeters of mercury. So in that range of severe to very severe, you can double the gradient and the actual load on the ventricle. And I think, therefore, it makes sense to define very severe disease based on a threshold probably of 5 meters per second, in whom, again, because of the high event rate, you should consider elective surgery in the asymptomatic phase. We'll talk about the elderly patients in particular a bit later. There's a special consideration, but we shouldn't forget the patient with moderate disease, because moderate aortic stenosis is usually progressive. So also these patients need to be followed, because if we lose them to follow up, they may have unfortunate outcomes. And indeed, there are some data highlighting the fact that early intervention in very severe disease is associated with an improved outcome. Obviously, dealing with aortic stenosis and assessing aortic stenosis by echo implies using peak velocity as a flow-dependent parameter and aortic valve area as a sensitive parameter. So if velocity is high, it is very specific for the presence of severe disease. And if the valve area is below 1 centimeter squared, it is very sensitive in order not to overlook potentially severe disease. If both match, it is easy, but sometimes the gradient or the velocity are low in the moderate range, and valve area, which is flow independent, might still be small. And in this instance, it is important to make sure that you didn't underestimate peak velocities using a dedicated pencil probe, a small echo transducer. Unfortunately, I've just ordered a new echo machine from a very solid vendor. So they did a proposal. They didn't offer this pencil probe in the initial proposal. So I asked them, I need a pencil probe. They said, it's not a big deal. It's 300 euros. But it's out of fashion. No one orders it anymore. And I just want to highlight it is fundamental to have this probe because in so many cases, this is just one example. The patient with a recording on the left from the 5-chamber view and on the right from a right peristernal view was this small dedicated probe, which makes the difference between moderate and severe stenosis, and this changes life expectancy for the patient. We see this in 20% of patients who present with gradients in between 3 and 4 meters per second who are symptomatic. So always use that probe. But obviously, some patients indeed have a reduced flow, either because their heart function is poor, such as low flow, low gradient stenosis, or because they have a small cavity in the hypertrophied heart where the cardiac output is reduced. These are usually elderly ladies. And this is where calcium scoring is now very useful. We used to use the butamine echo in traditional low flow, low gradient aortic stenosis. But if the valve is heavily calcified, it is highly suggestive of severe disease. And there are thresholds being proposed for men and for women, which obviously depend on the size. So don't take it that strictly. If you have a small man and he has a calcium score of 1,400, he may still have severe aortic stenosis. It is not an exact science. Be pragmatic in the decision making. So talking about aortic stenosis, obviously, it is a frequent disease and it is a disease of the elderly. You can see that the incidence is increasing in the elderly. There is diagnosed disease, and in the green bars, undiagnosed disease. These are patients who just haven't been screened. And the projections with aging populations are increasing, and more recent data actually confirm that calcific aortic stenosis prevalence has been increasing over the years, and that the prevalence is very high over the age of 70, even 65, increasing to the octogenarians. And it is a worldwide disease, obviously. And we also see this in observational data that many patients present between 70 and 80 years, but also a non-negligible group above 80 years of age. And these are patients that are actually more likely not to be treated, and sometimes without obvious reasons apart from the age. And if you look at life expectancy, and I think it is important to be aware and to make younger physicians aware of life expectancy. They're not always aware. If you have a 65-year-old, he has a life expectancy of 20 years. And if he lives through these 20 years, he'll be 85, and then he has another 6 to 7 years to live. And if he lives through these, he'll be 90, and he has another 5 years to live. So this confirms the hypothesis that if you celebrate more birthdays, you will turn older. And actually, you always get new cards. The further you go, you get a new set of cards if you manage to get to the next level. And also one concept that I think is increasingly recognized is biological age. There have been recent publications that biological age matters in functional decline. So if you see somebody who has a birthday in the passport that is old, but he looks fine, he's active, that matters. But elderly patients with aortic stenosis are a specific group of patients. We have looked at patients over the years of 70 years of age, and what we found is that in 30% they have immobilizing comorbidities, osteoporosis, degenerative spinal disease, arthrosis, trauma, severe COPD, or other conditions that limit their normal activities. But if you look at event-free survival, you see that the event rate for severe stenosis in the elderly is very high, probably higher than in the younger population, 90% needing surgery or intervention within 3 years. And again, peak velocity predicts the need of intervention with a threshold of 5 meters per second or more. What we found in that group were 9 cardiac deaths, which was higher than in the general population. And I think these elderly patients have fewer reserves. So I think the discussion should also be open to intervene earlier in older patients with very severe disease when they're fit, and now since percutaneous treatment modalities are available. The guidelines have changed over the years. There has been some uniformization, some standardization. Obviously, symptomatic patients need surgery, but also asymptomatic patients with depressed ventricular function. If they have very severe disease, peak velocity is over 5 meters per second, if they have a calcified valve and rapid hemodynamic progression or very elevated BNP, it is a class 2A indication where intervention should be considered, and it makes sense. And even very elderly have a relatively good outcome and life expectancy after procedures, even for 85-year-olds. And I want to highlight specific populations in the elderly that matters. One is the entity of mixed aortic valve disease, where you have both aortic regurgitation and aortic stenosis present on the same valve. You see this in the younger bicuspid population and in the older calcific degenerative population, where even the presence of moderate stenosis and moderate regurgitation can be significant because of the combined burden. And if such a patient is symptomatic, he needs treatment. And peak velocity, which reflects stenosis severity and the pendular flow related to aortic regurgitation, is a useful parameter to manage these patients. And just to highlight again, mild to moderate aortic stenosis, if they're just followed without regular controls, may progress to severe disease and may not be treated, and they may encounter an increased mortality. So definitely, asymptomatic patients are challenging. They need to be treated in a patient-centric way, considering the imaging findings, disease severity, the natural history, life expectancy, and individual risk, but also interventional risks to ideally define the timing and choice of a procedure, and ideally in patients who have multidisciplinary teams and high volume with excellence in imaging, intervention, and surgery, and in the ideal case, a heart valve clinic on site. And I think we should consider the patient-centered approach and the pathway with a referral, hopefully in a timely fashion, timely workup by a heart valve clinic, discussion in a heart team, and then either decision for follow-up or for therapy. And with that, I would like to thank you for your attention.
Thank you very much for this superb lecture on this very difficult topic. Professor Triposkiadis.
Thank you very much. First of all, George, I would like to thank you and the colleagues of the organizing committee for giving me the honor and pleasure to be here with you today. And I would also want to thank Professor Rosenhek for his lecture. Now, in order to decide if a patient with asymptomatic severe aortic stenosis, I usually ask an MRI because I believe nowadays we need tissue characterization. Now, what do you think about that? Can we say if it is severe or not, or can we identify high-risk patients with severe aortic stenosis with fibrosis, and how would the presence of late gadolinium enhancement would change your approach to diagnosis and management of the patient?
Thank you. I think this is a very good point. Indeed, the presence of late gadolinium enhancement and indeed of fibrosis, as documented by cardiac MRI, is associated with worse outcome. So that for sure. Unfortunately, we don't yet have the data whether that should trigger earlier intervention. How much time do we win? How much progression of fibrosis can we avoid? How much will a potential valve, prosthetic valve, lead to fibrosis because there is some degree of mismatch? So I think there are questions to be answered, but it is definitely a risk factor. It is certainly one element in the decision if a patient has severe aortic stenosis, but we don't have the final answer as to regression or avoidance of progression of fibrosis and the timing. And it becomes more difficult in the very elderly, but I think obviously we should do cardiac MRI, we should consider that information. In my personal practice, I think the most valuable and easiest parameter is peak velocity. Usually if that is high, it is unequivocal, it is related to the burden on the ventricle. If that is above 5 meters per second, you are facing a high-risk situation in the presence of normal flow, obviously.
Very often, having a mean age of our patients who are going TAVI, the mean age is 82. We face quite often the question about the real contribution of the severe aortic stenosis with a velocity of 4.2 meters in the symptomatic status of this patient. Usually we add the information of BNP or the evolution of the BNP, or occasionally, especially in women, the calcium score, which is the more accurate way to define the real contribution in this scenario of this elderly patient with this severe aortic stenosis, about the real contribution of the aortic stenosis itself in the outcome.
Indeed, it is a tricky assessment. Sometimes these patients are overweight, sometimes they may have pulmonary disease, so they may have other, or sometimes they're not trained, so they may have other reasons for mild symptoms. In case of doubt, in the presence of severe stenosis, however, I think we should offer valve therapy because they will progress anyhow if they're in good condition. I think there is one additional challenging group that we see now, and there are studies being performed, which is moderate stenosis and heart failure symptoms. And some patients may benefit from an intervention. Obviously, currently it is only done in randomized trials, but there are 3 randomized trials running. So even unloading a moderate stenosis in a patient who has heart failure symptoms might conceptually be beneficial, but we don't know the answer yet.
Also, another useful scenario is, as you mentioned, the moderate to severe aortic stenosis in a diabetic patient at the age of 75. In this scenario, we face this strict criteria for proper definition of the severity. Do you use the velocity ratio of the peak transaortic versus the outflow track ratio?
In cases of reduced flow, I think it is very useful. I would use both the continuity equation, but for means of orientation, also the velocity ratio is very useful, and then calcium scoring to confirm. I think there's also often an overlap with diastolic dysfunction in that group. So if heart failure is involved now, an SGLT2 inhibitor should also be added in that phase.
Well, as you
question.
Yes, Philippos.
Okay. Now, talking about aortic stenosis severity, both the valve and the myocardium come always to my mind. And what about a patient that has severe aortic stenosis, is asymptomatic, and let's say decent ejection fraction, but has problem with ventricular strain?
So if he's asymptomatic and he has reduced strain, I would use this as one element. I wouldn't operate just on that single criterion, but it is one element to add on. If there is more, elevated BNP, progression of velocity, for example, then I think that makes a case.
So it seems that it is of paramount importance, the strategy of regular follow-up in this scenario. So it's of paramount importance, Philippos, to establish a proper network, especially in this area of mid-range severity of aortic stenosis to deal with.
Absolutely. And the patients need a schedule. If they're lost, if they're on their own, outcome might be suboptimal.
Philippos?
No. Many thanks to Professor Rosenhek, and thank you both for the invitation and for the lecture, which I enjoyed very much.
Philippos, thank you very much.